Hello, it's a pleasure and honor to speak to you today. My name is Sreeja Natesan, and I'm APD at Duke University, and I'm excited to share with you our project entitled A Novel Tool for Assessing the Quality of Feedback in the Emergency Room, otherwise known as FeedER. So I have no financial disclosures to make. So let's jump right into it. So we know that constructive feedback is a powerful tool for impacting learning and clinical performance. In fact, it has been declared an essential component of residency training by the ACGME. In fact, the ACGME has even outlined the key components that are markers of high quality feedback. However, a feedback gap still exists. Despite over a decade of using competency-based milestone evaluations, EM residency programs are still facing inadequate feedback. There are currently no validated tools to assess the quality of feedback to help bridge this gap and help improve the feedback that's given in the emergency department. So there's two opposing sides. One side says, I never get feedback. You likely have heard this from your residents. The other side says, all I do is give feedback. You can guess who that comment comes from. Yes, these words echo through despite a multitude of publications, faculty development curriculum, and tools that exist. So my team set out to fill this gap. In our project, we aim to develop a feedback assessment tool to assess the quality of feedback in the emergency department. We sought to evaluate its psychometric properties and to understand the reliability and validity evidence of this assessment tool. Our overall goal of the study was to create two instruments, one for the faculty to self-reflect on the feedback that they give to residents, and the other for residents to use to globally assess the feedback that they actually receive within the emergency department. So the methods of our studies, this was a multi-center study that was conducted using a REDCap-based self-assessment survey of emergency medicine residents and faculty. We emailed the survey to participants at 5 academic centers in America and 1 in Thailand. So let's talk about our process. The first step was creation of the FeedER survey. So we identified 4 feedback domains based on the ACGME framework, based on what we found on their website. And you can look more into that based on this QR code if you're interested. So this consisted of timeliness, specificity, respect and communication, and action plan. Through our vigorous literature search, we actually found a 5th domain that we added, known as feedback culture. So using what we learned and the existing feedback tools, we developed questions that mirrored the domains that they were intended for. So this became our initial assessment tool, a 25-question survey with 5 questions from each of the feedback domains. So this led to our second step, which was the 2 Delphi rounds to ensure survey content quality. So we really wanted to ensure that we created questions that encompassed the components of quality feedback and that they reflected their respective domains. So this is why we sent the initial assessment tool to 17 content experts in medical education, feedback research, and emergency medicine through 2 Delphi rounds. So through this rigorous process, we were able to ensure respondent understanding of the item as intended, item coherence to the feedback domains, thematic saturation of the domain content, as well as time duration. So using this information, we further tailored our questions again, and I really wanted to share an example of FeedER after the 2 Delphi rounds. So we created 2 versions, a resident version and a faculty version, using a 5-point Likert scale. These 2 surveys actually mirrored each other in content. So an example would be, the resident version would read, feedback is given when I'm ready to receive it during my shift, while the faculty version would say, I give feedback when the resident is ready to receive it during their shift. Both of these would pertain to the domain of timeliness. So once we incorporated the changes, we entered our 3rd step, which was distributing the finalized survey via email. So we received IRB exemption and created the survey on REDCaps. We enrolled during March through October of 2019. So we sent a separate email to the faculty and residents of each of our enrollment sites linked to that finalized survey. So these are the 6 universities of my wonderful collaborators. We asked participants to take the survey only once. So this led to our final step, which was looking at the statistical metrics for psychometric validity as well as reliability. So I wanted to pause and talk about everyone's favorite topic, statistics. So we used the following statistical tools to evaluate our psychometric properties. So first was descriptive statistics of the frequency of responses. So basically how the question items use the Likert scale, and did they use a wide array of responses. The second was we used confirmatory factor analysis to really test whether the measures of the constructs were consistent with what we, the researchers, understood the nature of that construct to be. After that, we looked at one-factor model as well as a five-factor model to see if we can get a unique feedback score, but also if those questions that we developed fell into those 5 domains that we actually hoped for. And then finally, we looked at reliability based on the Cronbach alpha's internal consistency measure. So we wanted a reliability measure greater than 0.6, and that would essentially suggest that our sets of questions were closely related as a group. So let's talk about results now. So we were able to enroll 147 EM faculty and 126 EM residents out of a total of 200 and 250 respectively. We analyzed the use of the Likert scale for each of the questions to see if a skew existed. So although in general there was a slightly positive skew, likely due to the emphasis of feedback in medical education, we did see that there was a wide array of responses used on the Likert scale. So from a practical standpoint, it was really important for us to be able to generate a unique feedback score. So by analyzing the use of our data based on the one-dimensional model, we actually found that this was possible. So if you got a feedback score that was good, there's no issue, that's awesome. However, if you got a feedback score that was low, the downside is that you would never know which area to work on if we only used the one-dimensional model. So this is why it was important for us to use a 5-dimensional model as well, so you would know which area was strong as well as weak. So our factor analysis models show that the questions tend to be structured into those 5 domains just like we hoped they would. This meant that the questions within each of those domains actually appropriately overlapped in their content. So this is great news because it really confirmed that statistically, our questions could be grouped in the 5 feedback domains that we intended. Additionally, all of the factor analysis models showed adequate fit indicators. Finally, let's talk about reliability. So we evaluated the domains for reliability. We wanted to know if people tend to respond to questions in the same way. An example would be on timeliness. If they answered one timeliness question positively, ideally all of the questions within that same domain should be answered similarly. So remember the Cronbach alpha was the measure of reliability, and we wanted it to be greater than 0.6. So for our study, we actually found that this was 0.92, so we were really happy about this. We also found that this was strong for all of the other 5 feedback domains, as you can see here on this figure. So, we all know that in feedback, there's really not one right way to give feedback. Instead, there's one way to do it, and then the other way, and then the other way, and then the other way. And if I ask for a show of hands, I bet that each of you has your own technique and the style of giving feedback. So really the lens that we look at giving feedback is often colored by the perception of the resident and the faculty. However, this feedback gap really exists, and it's due to a lack of a validated, reliable tool to assess for the quality of feedback within the emergency department. And this is where we envision using this tool. So there is this tug of war on feedback between the resident and the faculty. We created this novel tool to assess the quality of feedback within the emergency department. It's a tool that the faculty and residents can take to give you a sense of their effectiveness of giving feedback. This helps to bridge that gap of inadequate feedback by being a reproducible, valid, reliable, and objective measure for understanding the feedback, and it's tied to those 5 specific feedback domains. So limitations of our study include sampling bias as well as the need for replications. And so this really leads to our next steps. So we would like to conduct further studies for replication to further evaluate other types of psychometric properties, and then also to obtain a wider population sampling. Providing an individual score can help tailor guided opportunities for faculty to improve feedback. There's also this other potential use in which the domains of feedback can be looked at based on an emergency medicine program to see which areas you're strong or weak in. So this has a multitude of scholarship opportunities that we hope to grow on. So in conclusion, BDR is a novel tool that we're really excited to share with you. It's a tool that's reproducible, valid, reliable, and provides an objective measure for understanding the quality of feedback within the emergency room. Furthermore, it's a novel in its utilization of questions that can be actually mapped out to those 5 feedback domains. So our hope is that we can use FeedER on an individual level and systems level to really identify which domains of feedback you're strong or weak in so that targeted educational interventions can be used. So we look forward to sharing more about FeedER with you in the future. Thank you so much for your time.
Hello, my name is Andra Blum. I'm from the Stanford University School of Medicine, and I'll be presenting the abstract, Wellness in Academic Emergency Medicine, Initial Exploration of the 2019 Survey of the SAEM Physician Membership. I wanted to thank my co-authors for their contribution to this important work and to also thank the program committee for selecting this abstract. I have no relevant disclosures. For background and aims, we know that wellness is a large problem within healthcare providers, particularly in emergency medicine. Wellness within academic emergency medicine is not well known or understood. We sought to survey the emergency medicine trainees and faculty using a standardized testing instrument. The SAM Wellness Committee evaluated and then added additional questions pertinent to the academic environment. The survey we used was the Stanford Physician Wellness Survey, originally developed by Tate Shanafelt and colleagues, and has been used on an annual basis for the Stanford faculty. The survey is comprised of approximately 20 domains, and each of those domains has between 4 and 8 questions. Domains may include professional fulfillment, burnout, interactions with the EHR, self-compassion, gratitude, and expectations of the working environment. There are 2 significant indices for discussion in this survey. One is professional fulfillment, and the other one is burnout. These are calculated and have been previously validated based on specific questions throughout the survey. So for most of our data, we will describe either professional fulfillment or burnout as an outcome. We hypothesized that professional fulfillment and burnout would differ in academic emergency medicine from that of previous studies in overall emergency medicine provider populations. Of a possible 5,771 respondents, 1,046 participated, which is 18% of that population. 43% were female and 23% were non-white. When breaking up the data by rank, we had representation from residents, fellows and assistant professors, associate professors, and then full professors as shown. In regard to residents, we're here looking at 2 distinctions between professional fulfillment and burnout, both by gender and by race. And whereas previous studies have demonstrated significant differences in professional fulfillment and burnout between these categories, we saw no differences in professional fulfillment and burnout between genders or race ethnicity. We found similar observations when conducting the same analysis with faculty. We found no difference in professional fulfillment and burnout between genders and race ethnicity. We then sought to examine specific academic questions that were entered by the Wellness Committee. The first one was for residents only, and that included, residency training is what I expected. And we can see that for each Likert scale point increase, that there was a significantly higher odds ratio professional fulfillment for residents. This one is for residents and faculty and discusses change in career. The specific question was, I have seriously considered pursuing a job outside of clinical medicine. Both residents and faculty showed an increased odds of burnout for each Likert point scale increase in their response. For this question, also pertaining to residents and faculty, working when sick, the question was, I regularly work clinical shifts when I am sick. This was associated with an increased odds of burnout for both residents and faculty, but no difference between residents and faculty. The next question is, the field of emergency medicine is what I expected. And this is showing the odds of professional fulfillment. And we can see that both in residents and faculty, the odds of professional fulfillment are higher with that response. However, once again, we notice that there are no differences between residents and faculty. This next slide examines rank and gender between professional fulfillment and burnout. We've divided the population by resident, junior attendings, which includes assistant professors and fellows, associate professors, and then full professors. Males are represented in gray, females are represented in red. And while we can see here that in general a trend exists that males report higher professional fulfillment and burnout, there are no differences among these groups for both rank and gender for both professional fulfillment and burnout. The closest one may be the one that draws your eye as professor in terms of professional fulfillment, where it appears as though males significantly are increased over females. However, the low number of respondents within the female professor category, a total of only 18, makes that a non-significant value. A few other faculty observations regarding specific academic questions. For each Likert scale point increase in seriously considering a job outside of the academic environment was associated with a lower odds of high professional fulfillment. Likewise, each Likert scale point increase in I have a clear understanding of the promotion process was associated with a 68% higher odds of professional fulfillment. In conclusion, emergency medicine providers and trainees are at a high risk of burnout. Previously shown differences in rank and gender are not apparent in this cohort. Likewise, previously shown differences in race and ethnicity are not apparent in this cohort. Lastly, meeting expectations of residency training in the field of emergency medicine was associated with significantly higher professional fulfillment. As for limitations, the survey study faculty represented a single society membership, which may have self-selected to be in academics. Academic questions that were added by the Wellness Committee were evaluated but have not been validated. There was somewhat limited survey participation of 18%. Next steps will include exploration of an academic wellness index similar to professional fulfillment and burnout, and further exploration of specific subgroups for themes. Thank you very much.
Thank you for this opportunity to present our research pertaining to young febrile infants. We are very appreciative of the efforts taken by SAEM to sustain and highlight research activities during these unprecedented times. Our research was supported by several federal grants and PCARN. The prevalence of important bacterial infections in febrile infants in the first 2 months of life is estimated at 8 to 10%. Most are due to urinary tract infections, and the rest due to invasive bacterial infections or IBIs, defined as bacteremia and bacterial meningitis. Experts recommend the use of various risk stratification algorithms in the evaluation of young febrile infants in the first 2 months of life to identify those at risk for important bacterial infections. Patients with positive urine analyses are at an unknown risk for invasive bacterial infections, especially bacterial meningitis. There are benefits and drawbacks to performing lumbar punctures in febrile infants. There is a balance between the benefits of knowing for sure whether the patient has bacterial meningitis by performing lumbar punctures on every febrile infant versus the risk of failed or traumatic lumbar puncture or iatrogenic complications, prolonged unnecessary antibiotics, not to mention parental anxiety and societal costs. Our prior work has demonstrated the substantial practice pattern variation in performance of lumbar punctures and hospitalizations in young febrile infants. The y-axis on the graph represents the proportion of febrile infants who received lumbar punctures on the left and those who were hospitalized on the right. The x-axis represents age by day of life until 60 days. The black arrows represent cutoffs at first and second month of life. Lumbar puncture and hospitalization rates were consistently 90% or above in the first month, and these rates dropped to less than 50% in the second month across the 26 participating PCARM sites. Recent data estimates the overall risk of bacterial meningitis in febrile infants with positive urine analyses at 1% in the first month of life and substantially less than 1% in the second month of life. However, the evidence is still not definitive because prior study designs have either been retrospective in nature or have used varying definitions and have had selection bias as they included only those infants that had lumbar punctures performed. The objective of our study was to determine the prevalence of bacteremia and bacterial meningitis in febrile infants in the first and second month of life with positive urine analysis. We performed a planned secondary analysis on data collected for the parent study, which was a prospective cross-sectional study of febrile infants 2 months and younger in PCARN EDs from 2008 to 2019. We included infants less than 60 days of age with fever, which was defined as a rectal temperature of 38 degrees centigrade measured in the ED or in the referring center or at home, and who were being evaluated for bacterial infections with a minimum of blood culture. For this analysis, results of the urine analysis had to be available for the patients to be eligible. We excluded critically ill appearing infants, those who had received antibiotics within 48 hours, and those with histories of prematurity or complex associated disease. We collected data on patient demographics, including the Yale Observation Scale score, which is a quantifiable score for patient appearance. We collected data on screening tests in the blood, including the white blood cell count and the absolute neutrophil count. We collected results of the urine analysis and CSF analysis and cultures from blood, urine, and CSF. Serum procalcitonin were analyzed if available. Patients' treatment and disposition were recorded. All febrile infants who did not receive a lumbar puncture and who were discharged from the ED received a phone follow-up to determine bacterial meningitis status. We defined urinary tract infection, bacteremia, and bacterial meningitis using widely accepted definitions. In the main analysis, we compared patient demographics, screening biomarkers, and prevalence of bacteremia and bacterial meningitis between febrile infants with positive versus negative urine analysis. We report our results stratified by 2 age cohorts, the first and second month of life. We performed multivariable analysis to identify predictors of bacteremia and bacterial meningitis in febrile infants with positive urine analysis. We enrolled approximately 7,400 febrile infants prospectively in the parent study. 97% of those infants had a urine analysis performed and were thus eligible for this study. Approximately 1,000 infants, or 15% of the cohort, had a positive urine analysis, and approximately 6,000 infants, or 85% of the cohort, had negative urine analysis. The prevalence of important bacterial infections stratified by positive and negative urine analysis are shown in the bottom row boxes. Of note, there was substantially higher prevalence of urinary tract infections and bacteremia in the positive urine analysis group. Infants with positive urine analyses were more likely to be younger and have higher mean temperatures. There was no difference, however, in the Yale observation score compared to those with a negative urine analysis. Additionally, infants with positive urine analyses had higher mean values for the white blood cell count, absolute neutrophil count, and the serum procalcitonin levels, and were more likely to be hospitalized. This slide reveals the distribution of urinary tract infections stratified by age. As expected, nearly 50% of febrile infants with positive urine analyses had urinary tract infections compared to less than 1% with negative urine analyses. These results were similar between the age cohorts. Overall, the prevalence of invasive bacterial infections were higher in infants with positive urine analyses, and these differences were similar in both age cohorts. Amongst the invasive bacterial infections, bacteremia rates were higher in infants with positive urine analysis in both months of life. As expected, the overall rates of bacterial meningitis were low in the entire study cohort. Of note, among the febrile infants in the second month of life with positive urine analysis, none of the 697 febrile infants had bacterial meningitis. Our prior research has identified procalcitonin as an important predictor for bacterial meningitis. And since procalcitonin was variably analyzed across the PCARN EDs, we developed two multivariable models to identify predictors for invasive bacterial infections in cohorts with and without procalcitonin. Among the 470 infants who had procalcitonin levels performed, only young age and serum procalcitonin were independent predictors of bacteremia and bacterial meningitis. Among the 1,047 infants who did not have procalcitonin levels performed, young age, temperature, and absolute neutrophil count were independent predictors of bacteremia and bacterial meningitis. Our study had some limitations. We enrolled a convenience cohort based on research staff availability. However, in a separate analysis, we did not find any differences in bacterial disease prevalence in the missed eligible cohort. Overall, there were very few cases of bacterial meningitis, which is reflective of the prevalence in this age group. Finally, PCARN EDs represent specialized pediatric centers and may not represent care provided in other settings. In conclusion, the prevalence of bacteremia is higher in febrile infants in the first 2 months of life with positive urine analysis compared to negative urine analysis. Therefore, all febrile infants in the first and second month of life need blood for biomarkers to identify those at higher risk for bacteremia. However, there were no cases of bacterial meningitis amongst the approximately 700 febrile infants in the second month of life with positive urine analysis. Therefore, lumbar punctures are typically not necessary in well-appearing febrile infants in the second month of life with positive urine analysis. We are presenting the validation of the previously developed PCARN febrile infant prediction rule, which includes urine analysis, later during this meeting, and we plan to undertake implementation and wide dissemination of the prediction rule in the immediate future. Finally, I want to thank my co-principal investigators, Dr. Cooperman and Dr. Ramilo, and all PCARN site investigators, research coordinators, and the data center for their help during this study. Thank you.